So it's always a privilege to welcome back one of our past fellows. Dr. Doherty was a fellow at the House Institute some time ago and has gone on to have a very great career. We're happy to welcome her back. She's currently a professor of otolaryngology at the University of Southern California, ENT department, and she's going to talk to us today on temporal bone histopathology, specifically about cochlear implants. So thank you for joining us, Joni.
Thank you for inviting me. So this picture is obviously well recognized by everyone who's been to the House Institute. The temporal bone lab was on the 4th floor, and in 2013 is when the lab moved over to UCLA, and it's called the House Temporal Bone Lab of UCLA now. But this research that I'm going to present is from many years, going back to when Joe Fayad was with the lab, and Fred Linthicum, was my mentor. So I just want to kind of do an overview of what we learned about cochlear implants through the years through histopathology. So basically, obviously, we're interested in this portion where the electrode array enters the cochlea and what kind of intracochlear changes go on after implanting the electrode array. The temporal bones are processed after death by donors, and specifically these are donors who have had a cochlear implant. Obviously, the way they're processed is takes about a year. They have to be decalcified and then embedded in celluloid in several steps, and then they are sliced on a microtome in horizontal sections. And so this figure that shows the labyrinth and the plate through it is the plane of section, and this H&E stain slide over to the right is an example of the horizontal section through the temporal bone. And we can learn a lot about what goes on with the inner ear anatomy as well as middle ear as well. And you can see here the close proximity of the internal carotid artery to the cochlea. And over here is a little remnant of the stapes and then the tympanic membrane. And over to the left, we have the organ of Corti and the lateral wall of the cochlea. So these are the things that we're specifically studying. Here's an example of a celluloid and embedded temporal bone with a cochlear implant electrode array in it, and another view from the side. And then the horizontal sections. And the electrode array, since it's metal, it needs to be removed from the temporal bone prior to slicing the sections on the microtome. These are 20 micron sections, and the blade is very delicate and quite expensive, and it'll get ruined if you try to slice through something metal. So we actually learn from just observing the path of the electrode array, which you can see on the lower left-hand side. There's the circular path through the scala tympani and some fibrosis around it. And then on the lower right, this electrode happened to go right through the lateral wall, the spiral ligament. And so these are changes, after implanting an electrode is particularly what we've been interested in. So this slide shows the ways that the electrode array can damage the delicate structures of the inner ear. It can lacerate the spiral ligament. It can also push up or elevate the basilar membrane and even avulse the spiral ligament from the lateral wall of the cochlea or the endosteum. This is a closer view of the previous slide where the electrode array is going through the spiral ligament lateral wall, basically the cochlea. It's affecting the cerebrovascularis as well. And you can see in the basal turn that there's some fibrosis here, as well as some new bone formation. And that's what happens when the cochlea gets damaged. It responds with inflammatory response being fibrosis, and then eventually due to lack of blood supply and oxygen, new bone forms within the turns of cochlea. So this slide is showing basically the modilus where the spiral ganglion neurons are. And so we can count the spiral ganglion neurons throughout the cochlea and use that to correlate with findings from the temporal bones, such as, damage that's taken place, and also correlate it with the cochlear implant performance. This slide up on the upper right shows the neurites or dendrites within the osseous spiral lamina. And then this is a closer view of the spiral ganglion neurons, and then a much closer view on the lower right of the spiral ganglion neurons. So here are the dendrites. I really like this slide because you can see the connections between the neurites or dendrites and the spiral ganglion neurons here. And when so on the right side, we have a cochlea with few spiral ganglion neurons, lower than the normal amount, and on the left, a very abundant spiral ganglion count. And this, represents the electrical signal. What is believed to take up the electrical signal is the spiral ganglion neurons themselves. So one of our important questions was, what is most important for cochlear implant function? Are the neurites important? Are the spiral ganglions important? Are they the dendrites or neurites even necessary? What is being stimulated there? It's always been assumed that it's spiral ganglion neurons, and that the dendrites may play a key role. So we looked at different effects and different outcomes with these things. Intercochlear insertional trauma, as shown on this little slide here, a cochlear implant electrode pathway going through the lateral wall results in fibrosis and new bone formation. And that's something that's been proven, shown over and over again by multiple researchers who study this kind of histopathology. But another thing we were interested in is, what is the effect of chronic electrical stimulation? So we looked at patients who had many years of use of their cochlear implant before we were able to examine the temporal bone. And then, what is the minimum number of spiral ganglion neuron receptors necessary for an adequate response? Here's an example of a temporal bone with very few dendrites, and also a paucity of spiral ganglion neurons as well. So it's pretty easy to tell when they have or have not the adequate number of dendrites. And then, like I said before, we count the spiral ganglion neurons, and there are averages by age and by turn of the cochlea that we compare with. So what is being stimulated? Most of the temporal bones with cochlear implants that we looked at did not have any remaining hair cells. Some had a few in the apical turn. More than 75% of the bones did not have any peripheral processes, so no neurites, dendrites. All had at least some remaining spiral ganglion cells, but some had very few. So we wanted to correlate this. And so this study, this is a kind of a compilation of many studies that have been done from the lab on cochlear implantation, histopathology. So the morphologic evaluation, just basically looking at the health of the spiral ligament, stria vascularis, the hair cells, peripheral processes, and spiral ganglion neurons, and then paired comparisons between implanted ears and non-implanted ears. when available, when we did have that in the early days, was only 8 patients, but since then there have been many patients, and it's been shown, and I'll show you some of the data later, that there really isn't a difference in the spiral ganglion counts between the implanted and the non-implanted ear, indicating that long-term use of a cochlear implant does not affect the spiral ganglion neuron population. On the lower right is a 3D reconstruction of the cochlea, where the green is the pathway of the electrode. The red is fibrosis, and the white is new bone formation, and the blue is basically healthy cochlea. And we use the Amira for doing the reconstructions of these. So using the sequential slides, and then basically manually outlining the areas and putting it together in a 3D reconstruction. This is another 3D reconstruction on the upper left, showing also the neurites or dendrites. These are the segments of the cochlea. So when we count spiral ganglion neurons, we segment it into the areas for the apex and the base, and in between, basically, for the averages. Another example, then this is some early data that showed that the total spiral ganglion cell count did not really correlate with the speech discrimination score or, word understanding score in cochlear implant users. So there's a poor correlation. Some with very high spiral ganglion counts had low performance, and some with very low spiral ganglion neuron counts, like this one, had better performance. And in addition, the duration of deafness did not really correlate to the total spiral ganglion count. So indicating that long-term or chronic use of a cochlear implant does not affect the spiral ganglion neuron population. And this is an older slide too, showing the correlation between the spiral ganglion neuron cell count on the horizontal or x-axis, and then dendrites versus no dendrites. So the yellow X's are the ones that had dendrites, and the green X's are the ones that do not have dendrites, and then their performance scores. So again, there's really not a good correlation, because this green X up here is basically above the mean of the cochlear implant performers, despite the low spiral ganglion neuron count and no dendrites. And so again, showing the damages and the within the lateral wall, you don't see a lot of new bone formation, but you see a lot of fibrosis within the scala tympani on this slide. And there's a healthy neurite count, and there's a healthy spiral ganglion population within the cochlea. And then I just wanted to just correlate a few other things that, we see when we do cochlear implants. Like this upper left slide is a case that we studied of a really severe cochlear otosclerosis patient who had cavitations within the cochlea. And this is one of the reasons why, patients with severe cochlear otosclerosis who get cochlear implants have issues with, cross stimulation, sometimes of the facial nerve, because of this porous bone and the close proximity of the facial nerve in the labyrinthine segment to the cochlea. And this is an example of that. So this is the portion of the cochlea with the facial nerve path and the geniculate ganglion here. So then I wanted to kind of shift to another topic that we studied pretty deeply, along with our colleagues at Mass Eye and Ear in the histopathology lab there, and also with UCLA with Akira Ishiyama. So we studied factors that may contribute to residual hearing preservation in cochlear implant recipients. And it had been proposed that insertional trauma to the ductus reuniens is a mechanism to explain the high prevalence of cochlear hydrops that we see in cochlear implant recipients. And this has been proposed to lead to the low frequency hearing loss in patients with residual low frequency hearing at the time of implantation. So we studied patients with multi-channel cochlear implants. I mean, these are temporal bones, obviously. So but we had some data on their performance, and we had some, data on their cause of hearing loss and things like that. With the newer designs of electrodes, there are many improvements in the technology and many iterations of development, like the short electrodes, the slim straight for hearing preservation, and then also the modular hugging electrodes. Hearing preservation has been a newer goal with the hybrid or electrical acoustical implants. They are indicated or an option in patients with some low frequency hearing remaining that is at least 60 decibels or better. And the preservation rates vary highly. It's generally around 50%. And that's what I quote to my patients. But what we wanted to investigate further is what determines the hearing preservation. So cochlear implant insertion injury has two types. There's trauma that is immediate, caused by the path of the electrode on the intracochlear structures. And there are also delayed lesions defined as new fibrous tissue formation and new bone formation or neuroosteogenesis that is formed secondary to this initial trauma. And what our data and others have shown is that this, potentially leads to endolymphatic hydrops, resulting in loss of that low frequency hearing. So this is an example of insertional trauma where the endosteum is violated when the electrode array was inserted, and you can see the abundant fibrosis and some new bone formation within the scala tympani. So you can see that the amount of insertional trauma kind of correlates with the amount of new fibrosis and new bone formation, and especially when the endosteum is violated, it results in a lot more damage. And this is another example of violating the endosteum. All this new bone formation occurs within the cochlear wall. So new bone formation happens when tissue gets anoxic, within the cochlea. We know that lack of blood supply eventually leads to new bone formation and fibrosis within fibrosis, basically. And that is an example is when we do a translabyrinthine acoustic neuroma removal. If you look at the cochlea years later, many times it's ossified completely. So this study was a kind of a two-part study on insertion, comparing insertion through a cochleostomy, through the round window, and through a round window enlargement. And this is just kind of an outline of how we kind of displayed the bones and looked at the angle of insertion. So cochleostomy was generally a little bit anterior to the round window. And this would be a round window enlargement when some of the overhang of the round window niche is drilled off, and it can violate the crista fenestra, which also leads to more damage, new bone formation, and sometimes plugging of the ductus reuniens just due to the fibrosis and new bone formation. This slide is from a paper from Joni's group at Mass Pioneer, showing the complex anatomy of the hook region of the cochlea. So this is a round window niche here, and the scala tympani is quite narrow actually at that point, and you have the spiral ligament just adjacent to it, and the ductus reuniens is right down here, very close proximity. And as you go a little further deeper in, there's the scala tympani enlarges, and it becomes, you know, a little bit more accessible. And I think that's probably the reason behind our initial, you know, thought that the cochleostomy was the better way to insert a cochlear implant electrode, because for many years that was the way it was done, even with hearing preservation surgery attempts with short electrodes. And it was hotly debated. And, you know, I think a lot of you guys probably remember that. And now everybody, you know, pretty much goes for the round window insertion. So does the insertion technique affect the hearing outcome? We looked at 12 human temporal bones from 9 cochlear implant recipients. 3 were bilateral. We excluded cases with meningitis. The mean duration of implantation before death was 8.7 years, with a range up to 24.5 years. And we did the 3D quantification using the MIRA 4.1 for this study of the new fibrosis or ossification within the cochlea. And that was compared to the CI insertion technique, which we could see histologically, basically whether they did a round window insertion, cochleostomy, or a round window enlargement. And the extent of the damage was estimated on a 0 to 4 scale. And then which scala were involved with the electropath was recorded, and whether the ductus reuniens was blocked with fibrosis from the scala vestibuli or new bone formation. And then finally, whether hydrops was present and whether hearing preservation was achieved. So this is a drawing of the labyrinth, and just to clarify what the ductus reuniens is and where it is. So this is the hook region of the cochlea, and the ductus reuniens basically connects that to the endolymphatic duct and endolymphatic sac. So it's responsible for the egress of the endolymphatic fluid, and if blocked, endolymphatic hydrops occurs. This is a histological slide of a patient who received a round window insertion. And you can see that there's pretty minimal trauma within the cochlea. You don't see a lot of fibrosis or new bone formation. Did someone have a question? I just heard. Okay. This is another round window insertion. So there's pretty much minimal trauma. This was a, I think this is, yeah, this was, sorry, they did do a little bit of round window enlargement in this one. So you see slightly more fibrosis there. And this is via cochleostomy, and you see all the surrounding fibrosis due to insertional trauma, due to drilling, and possibly, you know, blockage of the either, you know, the ductus reuniens or the scala vestibuli. And then here we are. This is a classic example of insertional trauma leading to fibrosis and new bone formation. and you can see the endolymphatic hydrops is present. And so that was what we were looking at. And here's another example of a cochleostomy insertion with new bone and hydrops. You can see the Reisner's membrane bowing out. Here's another example, the hydrops. And that one we saw already. We saw it. Okay. So location is important so this person got lucky because their Ductus Reuniens actually didn't get blocked despite the extensive new bone formation within the scala tympani, but there's none in the scala vestibuli. So this was how we did our study. We did using the Mirror 4.1, basically slide by slide kind of outlines the electrode path. The red again is the fibrosis, the white is the new bone formation, blue is normal. And so we kind of calculated on each turn the amount and then tabulated the results. And with the round window insertion, there was much less fibrous tissue. However, it was not statistically significant because of the large standard deviation. There was much less new bone formation, which was significant. And the total new tissue was, as you can see, much lower. However, it was barely statistically significant, probably because of the small number of cases that we looked at. This is an overall view of what we were studying. Basically, was there a cochleostomy, and was their fibrosis or new bone within the scala vestibuli? So it's 100% yes and yes, and this is the cases that had hydrops. So looking at all the cases with hydrops, they all had a cochleostomy and they all have hydrops. And then we also looked at spiral ganglion neuron counts, and they're really not affected. I mean, this one is lower in the affected ear, but when you look at them all together, there's really no difference. In fact, some of the bones have more spiral ganglion neurons in the implanted ear. And then these are the cases with no hydrops, and the majority of them had a round window insertion, except for three, except for three. And the majority of them had no fibrosis within the scala vestibuli and Ductus Reuniens, except for one that had a cochleostomy. Two that had a cochleostomy. And so overall, it just indicates that the round window insertion leads to fewer cases of hydrops, and the cochleostomy insertion leads to hydrops and potentially loss of residual hearing. And this is a case of, this was Bruce Gann's patient that was implanted with the nucleus hybrid S8, the short electrode. The electrode path here is within the scala tympani, but involved the spiral ligament, causing fibrosis in the scala vestibuli and hydrops. This is the collapsed Reisner's membrane, but you can see kind of where it was, and that's an artifact of the fixation process. But this patient was, a hearing preservation patient and experienced hearing loss at 18 weeks after surgery. So in conclusion, damage to the spiral ligament and or scala vestibuli endosteum produces fibrous cell proliferation and may impair function of the ductus reuniens, limiting the egress of endolymph and leading to endolymphatic hydrops and low frequency hearing loss. Round window insertion is best, and if a cochleostomy is necessary, it's recommended to use the soft surgery technique to avoid damaging the endosteum and enter into the scala tympani. This is the recommended or optimal position for a cochleostomy if it is to be performed. And this is again from that paper from Joni's lab at Mass Eye and Ear. This is what they recommended, and this is where I like to do my cochleostomies. I remember that was also hotly debated many years ago. And then in summary, cochlear implant performance does not correlate well with dendrite or spiral glandular neuron counts in temporal bone specimens. Duration of deafness does not correlate with spiral ganglion neuron counts or dendrite counts for that matter. So chronic use of a cochlear implant does not damage the neurons. And the round window insertion is preferable for residual hearing preservation. And I just want to thank everyone who contributed to this work. Fred Linthicum, the late Fred Linthicum, the late and great Fred Linthicum, I should say, Jose Fayad, Akira Ishiyama at UCLA, Celine Richard was a visiting scientist from France. She's a neurotologist from France, and she spent a year in the lab doing these studies with me. And then Alicia Quinnell at Mass Eye and Ear, Karen Berliner helped with statistics, and Ivan Lopez is at UCLA. He works with Akira Ishiyama in the lab, and Anna Cordero is the histotechnician who's been with the House Temporal Bone Lab for 35 years, and she's over at UCLA with them now. And then all this work was supported with by the NIDCD consortium grant. Thank you.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.